want you to just picture this for a second. It's, say, a Tuesday. You're busy, you're rushing through your day, you grab a quick lunch, maybe it's a sandwich or a crisp apple.
Something you've eaten a million times.
Exactly. You take a big bite, you chew, you swallow, and this time it just stops.
It doesn't go down.
No, it just halts right in the middle of your chest, behind your breastbone, and you get the little flash of panic. You sit up, you grab water, and you're trying to, chase it down.
That is a terrifying feeling.
Yeah.
It's so visceral. And for the patient we're talking about today, that wasn't just a fluke. That became her reality.
Welcome back to the deep dive. Today, we are not just talking about heartburn. We're looking at the mechanics of why that food gets stuck. We're diving into esophageal peptic strictures.
And our guide for this is Dr. G.S. Raju. We're pulling this from a really fantastic lecture he has on his YouTube channel called Pathology of Esophagus Peptic Stricture.
And Dr. Raju is just the perfect guide for this. He looks at the esophagus almost like an engineer looking at a faulty pipe. It's fascinating.
He really does. He takes us from that feeling, that stuck feeling, all the way down to the microscopic level, the cellular warfare that causes it.
So let's start with his case study, the patient from the video. Because her story, honestly, it sounds so incredibly common.
It is. It's a very typical story, which is why it's so important. This is a woman who'd been dealing with acid reflux for a few years. And, like a lot of people, she was just sort of self-managing it.
Taking over-the-counter antacids, that sort of thing.
Yeah, exactly. The classic Papa Tums and power through approach. Probably just ignoring the mild burning, thinking, I've got this.
We've all been there.
But then, a few months before she sees Dr. Raju, the game changed. She developed what's called dysphagia.
Which is the clinical term for difficulty swallowing.
Correct. But the detail here is really important. It was specifically with solids. Sandwiches, meat, apples, liquids went down fine. And that progression from long-term reflux to suddenly a mechanical problem getting food down, Dr. Raju flags that as the classic story for a stricture.
Okay, so let's unpack that word, stricture. It sounds pretty severe. What are we actually talking about here?
In the simplest terms, it's a narrowing. The pipe, your esophagus, has physically become tighter. Its diameter has shrunk.
And the whole mission for this deep dive is to figure out how we get from, I have some heartburn after pizza to my throat is physically closing up. It feels like a huge leap.
It does feel like a leap, but Dr. Raju maps it out as this really logical, if destructive, chain of events. It's a ladder of pathology, and it all starts with that one culprit, acid reflux.
Stomach acid going where it really shouldn't be.
Exactly. And, the stomach is built for it. It's an acid tank lined with special cells, thick mucus. It can handle a pH that could, dissolve metal. The esophagus, though.
It's just the hallway to the tank.
Right. And hallways are not built to hold acid, so when that acid splashes up, it's causing a chemical burn.
Mm-hmm.
And Dr. Raju says the severity of that damage is basically a math equation. It's the volume of acid, the duration of the exposure, and, how strong your own esophageal lining is to begin with.
So it's a battle of attrition, basically, the acid versus the lining.
And when lining starts to lose that battle, you get to the first rung on Dr. Raju's ladder, esophagitis.
Which is just inflammation.
Pure inflammation.
Yeah.
And yeah, a doctor can see it. During an endoscopy, it might look really red and angry. Or sometimes it's microscopic. You need a biopsy to see the immune cells rushing in.
But if the acid just keeps coming,
then the defense collapses. You get to the next phase, erosion. The top layer of that lining actually breaks down. It sloughs off. If that break goes even deeper into the wall, we call that an ulcer.
Ouch. Okay, so we're not just talking irritation anymore. We're talking open wounds inside your chest.
Exactly. And this is where the story gets both fascinating and, in a way, kind of tragic, because the body does what it's designed to do. It tries to fix it.
It tries to heal.
It does. But think about how the body heals a deep chronic wound. It doesn't always make perfect new skin. It makes scar tissue. And what's the one thing we know about scar tissue?
It's tough. Yeah. And it pulls, right? It tightens.
It contracts. That's the key. Think of a bad burn scar on your arm. It pulls the healthy skin inward.
Oh, I see where this is going.
As that scar tissue forms inside the esophagus, circling the tube, it tightens. It's like a drawstring bag being pulled shut. That tightening, that is the stricture.
Wow. That is incredibly ironic. The body's attempt to repair the damage from the acid, the scar is the very thing that stops you from eating your sandwich.
That's the paradox.
Yeah.
The stricture is the aftermath of the body's clumsy, desperate attempt to heal itself from chronic acid. The healing process becomes the obstruction.
Dr. Raju shows what this looks like right through the endoscope. I imagine the difference between a healthy esophagus and this is pretty stark.
It is night and day. And he spends time on this because it's so important for diagnosis. A normal, healthy esophagus, he says, has a nice pink squamous lining.
Let's pause on squamous. What does that mean visually?
Think flat, smooth cells, almost like the inside of your cheek. It's pale pink, it's uniform. And there's this really clear border where that pink ends and the stomach begins.
And what about the stomach?
He uses this great phrase. He calls the stomach lining beefy red.
Beefy red, okay.
Yeah.
That paints a picture. A little gross, but you get it.
It works, right? It shows you all that blood flow and robust tissue. So normally you see this sharp line, pale pink meets beefy red. It's called the Z line.
But in this patient with a stricture,
That whole geography changes. And the stricture itself, the benign scar tissue one, Dr. Raju describes it as looking nice, clean, and smooth.
wait, nice and clean. That sounds weirdly positive for something that stops you from swallowing.
It is confusing, but it's a purely visual term for the doctor. It just means the narrowing is uniform, it looks dry, there isn't some jagged, messy tumor there. It's just a tight, smooth ring of scar tissue. It looks quiet.
Okay, I get it. It's not chaotic, it's just tight, like a smooth bottleneck.
Exactly. But before we move on from the visuals, there's another path this can take. If someone has had reflux for a very long time, long enough to scar, Dr. Raju points out another change can happen that's, well, it's a lot spookier than a scar.
Are you talking about the cells changing their identity?
I am. This is one of those things in biology that just blows my mind. If the acid reflux keeps up for years and years, the esophagus it gives up. It realizes that being lined with these delicate squamous cells just isn't working. So it makes a radical change.
It switches the lining to what?
It transforms into a columnar lining, more like what you'd find in the intestines. You literally get intestinal cells growing in your throat. It's a condition called Barrett's esophagus.
That's incredible. It's like the body is saying, fine, if you're going to treat me like a stomach, I'll become a stomach.
It's an amazing adaptation, but it comes with a huge, huge price. And Dr. Raju is very clear on this. While those new cells can handle acid better, they're unstable. Barrett's esophagus is a known precancerous condition.
It can turn into esophageal adenocarcinoma.
Yes. Which brings us to a really crucial distinction he makes. We've been talking about benign strictures from scarring. But a narrowing can also be caused by a tumor, right? A malignant stricture.
And that's the real detective work, I guess. Figuring which one it is.
This is where Dr. Raju goes from pathologist to investigator. Is this a benign stricture, just a scar? Or is it a malignant stricture, a cancer physically blocking the way?
Do they look different on camera? You said the benign one is clean and smooth.
They usually look very different. He says a malignant stricture, a cancer, often has nodules, ulceration, and this is a key. It bleeds easily.
So it looks messy, angry.
Exactly. Messy, angry, irregular, compared to that smooth, dry ring of a benign scar.
Okay, so if a doctor looks down there and sees a smooth, clean narrowing, they can just say, good news, it's benign.
Absolutely not.
Really? Even if it looks nice and clean?
Even then. And Dr. Raju is so emphatic about this. This is the big rule of thumb. You cannot judge a stricture by its cover.
But why not? If it looks benign.
Because looks can be deceiving. There's the type of cancer that can spread just underneath the surface lining. So it creates a narrowing that looks smooth, but it's actually cancer underneath.
So the visual check isn't proof.
It is not proof.
Yeah.
Dr. Raju insists you must take a biopsy. You have to take a piece of that tissue and look at it under a microscope to be 100% sure there are no cancer cells hiding in there. Never, ever assume.
That makes total sense. The stakes are just too high. So let's go back to our patient. She gets the scope. The biopsy comes back benign. It's just a scar.
Right.
So they put her on medication. Things like omeprazole, Prilosec, proton pump inhibitors.
Yes, the standard first line of defense. And Dr. Raju explains what those drugs do, and really importantly, what they don't do.
What do you mean?
Well, the PPIs stop the acid production. So the active inflammation, the redness, the ulcers, all that settles down and heals. The fire is out.
That sounds like a success. Problem solved.
It's a partial success. The drugs put out the fire, but they didn't rebuild a house.
The scar is still there.
The scar is still there. The medication fixes the active chemical damage, but it can't dissolve the tough scar tissue that's already formed. The pipe is still too small.
So she still can't swallow the apple.
Right. And before we get to how they fix that, Dr. Raju takes this quick detour. He points out that acid reflux isn't the only cause of these benign strictures.
Oh, right. He mentioned some other causes that were much more dramatic.
Yeah, frankly, they're quite disturbing. The first one is corrosive strictures.
That sounds horrific. What is that?
This is when someone ingests a strong acid, or, more commonly, a strong alkali. He specifically mentions drain cleaner.
Oh my gosh, how does that happen?
He says it's usually either accidental ingestion, someone stores a chemical in a water bottle, tragically, or a suicide attempt.
And the damage from that must be instantaneous.
It's immediate and catastrophic. Unlike reflux, which is that slow drip over years, drinking something like lye causes massive chemical burns. And when those burns heal, they form these very severe, very long strictures.
Just awful. And what was the other cause?
Radiation strictures. This is basically collateral damage. If a patient is getting radiation therapy for, say, lung cancer or lymphoma, the esophagus is often right there in the radiation field.
So the beams that are meant to hit the tumor also hit the esophagus.
Exactly. And that radiation damages the cells. And just like with acid, the body's response to that damage is to heal with scar tissue. And you get a stricture.
It really just shows how delicate that tube is. Whether it's acid over a decade or drain cleaner in a second, the body's response is the same. Patch the hole with the scar that makes the pipe too small.
Which brings us right back to the mechanical problem. The pills didn't open the pipe for our patient. The fire's out, but the hallway is still blocked.
So what does Dr. Raju do? How do you widen a pipe deep inside someone's chest?
You don't have to replace it, thankfully. You have to physically stretch it. The process is called dilation. And honestly, it's a lot like plumbing.
Dilation, like dilating your eyes.
Similar idea, making an opening bigger, but with a lot more physical force. He shows two main tools. The first is called a bougie dilator.
A bougie. That's a fun word.
It is a fun word. It's basically a long, tapered, flexible tube. It's thin at the tip and gets wider. They pass a guide wire through the stricture first, then they slide the bougie over the wire and gently push it through.
So they're literally just pushing a wedge through the blockage.
Pushing is the right word. As that tapered tube moves through, it exerts this outward radial force. It gently but firmly stretches and sometimes tears that scar tissue to open up the diameter.
It sounds kind of primitive in a way. Just push something through it.
It's mechanical, but it works. The other tool is maybe a bit more high-tech, the balloon dilator.
Okay, I can picture this one. You put a balloon inside and inflate it.
That's pretty much it.
Yeah.
They pass a deflated balloon right into the middle of the narrowing. They line it up perfectly. Then they use a syringe pump to push water into it.
Water, not air.
Water is incompressible, so it gives you really precise control over the pressure. And as that balloon fills, it expands with a lot of force. And that force just physically pushes the walls of the stricture outward. It cracks the scar open.
The goal being just to get the diameter back to normal.
Exactly. To get it wide enough so the patient can swallow a piece of chicken without that moment of panic.
It's just amazing that we can do that without major surgery. Just go right down the throat.
It is. But Dr. Raju does warn that it isn't always a one-and-done fix.
Oh. It can narrow again.
It can. Scar tissue is stubborn. It wants to contract. So sometimes patients need to have repeat dilations over time.
Which brings us full circle.
It really does.
So when you look at Dr. Raju's whole lecture, what are the big takeaways? What should you and I be thinking about the next time we get a little heartburn?
I think the biggest one is that chronic acid reflux isn't just an annoyance. It's not just about propping up your pillows. It is an active biological process that is changing the actual architecture of your body.
It's changing the blueprints.
It is. We saw that whole ladder from inflammation to erosion to ulcers and then to the body's response scarring. And that scar, which is meant to heal, it creates a whole new disease.
And for this patient, it meant she ignored the symptoms until the basic mechanics of her body started to fail.
That's the lesson. Early intervention really matters. If you catch reflux back at the inflammation stage, you can treat it with medicine and prevent the scar from ever forming. Once that scar is there, you've crossed a line from a chemical problem to a mechanical one.
And then you're looking at balloons and bougies.
And no one wants to have to chase their lunch with water every single day.
It makes you think about this balance between the body's resilience and its fragility.
That's what I found so profound. The body is incredibly resilient. It will scar over. It will thicken. It'll even change its entire cell type to Barrett's just to survive the acid. It fights so hard.
But that very resilience, that drive to heal, is what causes the problem.
It is. The healing is the obstruction. It's this biological irony where the body protects you from the acid, but in doing so, it stops you from feeding yourself.
Yeah.
And you need a doctor, like Dr. Raju, to step in and fix the fix.
Wow. That is certainly something to chew on. Carefully, of course.
Very careful.
Thank you for walking us through this. It was a fascinating deep dive into Dr. Raju's work.
My pleasure.
And thank you all for listening. We hope this gave you a new appreciation for what's going on behind a simple swallow. It's a complex machine. Take care of it. We'll see you next time.